like to really get back to your first question in terms of the glycemic control with microvascular complications. Sure. We have data now, US level data, showing that the rates, the actual risk of a patient developing microvascular complications with type 2 diabetes have been reduced over the last 2 decades, which corresponds very well to the efforts that we have all taken in educating our colleagues on how the importance of good glycemic control. We are seeing the benefits of that, and I want everybody to be aware that this is not just, anecdotal or just mythical. It's really happening.
I mean, it was a spectator sport where I came from, to look at all the diabetes experts hammering away at getting glycemic control and saying they're going to get a whole bunch of people hypoglycemic. Is it worth it? But what you're telling me is, yeah, if you're careful, it is worth it.
If you can get the patient's A1C, this is my mantra, to lowest possible without complications and without undue burden for what we're asking the patient to do, that should be our goal.
No, let's rephrase it. The lowest possible without hypoglycemia.
That's what I said.
All right, so
you didn't say hypoglycemia.
Let me then ask the obvious next question. Effective glucose control, when I look at cadres of patients, it's tough. This is not an easy job to do. So what are some of the reasons that effective glucose control is so hard to get?
Well, first of all, you have to deal with the complexity of the disease. The disease is changing. So diabetes today in a patient changes over the life of the time course of that patient. The components, patients generally tend to gain weight, become more insulin resistant, lose insulin secretory status. So the medications that work at the beginning, which may be metformin and lifestyle modification, may hold a person less than 7%. But over time, there's going to be worsening. There's going to be worsening of insulin resistance and worsening of insulin secretion. So that's one of the features, but there are many other components.
All right, what you mentioned here, I think I don't want to lose in the noise, that you can parse this out a little bit, right? There's insulin resistance and decreased insulin secretion. Do you attack both of those? Are they attacked with the same mechanism? How do you go about with that?
Well, we haven't had a lot of, unfortunately for the treatment of insulin resistance, there has not been a lot of effective therapies. Weight loss, of course, and exercise is our strongest and most potent therapies that everyone can do to some greater or lesser extent. The insulin sensitizing world, which started with the thiazolidinediones, where it looked like they were going to be terrific insulin sensitizers, but had a lot of baggage and a lot of side effects, which have unfortunately led to very infrequent prescription.
And it seems to me, the larger the palette that you've got to work with, the more difficult it might be for people to adhere to a complex regimen and to self-monitor. And to some degree, diabetes is one of the classic diseases where people have to self-monitor. How do you do it?
I just want to say one other thing is that the new medications that have come have made it easier.
Okay.
I mean, they truly have made it much easier. Even though we've now got 11 or 12 or more than a dozen, or in the range of a dozen classes of medication, many of them have made it much easier. The pens, the combination of medications at one time, combination therapy, particularly in insulin and the medications that can go with the GLP-1 receptor agonist together, have improved in the simplicity of insulin administration.
You know, one of the big issues I see, at least in dealing with my patients and then colleagues that I work with in primary care, is still that old concept that diabetes is a patient's fault, and if only they could follow the right diet and exercise and lose weight, they wouldn't need medication.
And by the way, it's not just diabetes. The cardiologists believe this too. You're eating too much red meat. Pick a disease, any disease.
But I think it's specific. I really do think patients with diabetes are looked at with the idea that their disease is their fault, and they sense that, and because of that, you know, they are reluctant to start medications, or the providers are reluctant to start medications right away, and they don't understand the approximately 50% reduction in beta cell function at the time of diagnosis. And some of that can come back, but most of it can't. And so, yeah, this is a big problem in terms of, you know, having both the patient and the doctor on the same page saying, this is an important disease, we need to move forward and treat it aggressively.
You know, that surprises me. I guess I see patients in the hospital who already have the diagnosis, and they don't seem to say to me, gee, I was bad, so I caught diabetes. They usually say to me, I've got diabetes. Do you guys agree? The patients
Well, I
think it's
mean,
their
there's
fault?
something that the patient of mine told me many, many years ago when he was diagnosed with diabetes, and I follow over time. And one day he comes and said, you know, doc, ever since I got the type 2 diabetes, I'm a much healthier person. And you know, it is true, because if you do the right things, if you start exercising, losing weight, watching what you eat and so on, some smooth lifestyle changes, you could do very well. But I want to go back to the issue of the blame game. Yeah, I mean, people tend to blame on the patients, but there's also a little bit to blame on us. And that's where comes the issue of the clinical inertia. Because, I mean, we have 10 different classes. Things are much easier, as Henry says. But people just don't intervene. And there's study after study after study that shows that people with an A1C of 7.5, 8%, they are supposed to come every 3 or 4 months, and there's no action to do and utilize these.
So that's our fault. That's the healthcare team's fault.
But
by the way, it is a team. right?
I mean, just think of the medications that have come in since 1995. We had sulfonylureas and insulin before 1995. Metformin came on the scene in the United States in 1995. Since then, there have been a plethora of medications, both injectables and orals, often in different combinations and different dosages. So for the person who's not dealing with diabetes, it's very difficult to keep up on what's going, you know, the approval process, the complications, the
Sure,
side
but
effects.
we need to keep it simple.
And
we need to keep it simple. And we need to be a little bit more direct in terms of the guidelines.
I think there's a change coming in the way we practice. The old model where you see somebody, where you only have 10 minutes or 5 minutes to, you know, change something, and the patient doesn't want to lower their A1C goal or take another medication, say, all right, we'll do it next time, and they don't come back for a year. Today, with electronic medical records, we can prompt people, we can coordinate care better, and I see that we're going to have a system change in managing those 50% of people who are above goal, and focus on them making appropriate choices and implementing them.
But there is still an issue of adherence. And study after study have shown that people don't take the medicines as
Poor
supposed
adherence,
to.
for multiple reasons. Not just simply because they don't want to take the medication, but because it may be difficult to get, it may be very expensive, it may have side effects. There are just a host of reasons that prevent people from doing what they should do.
But that's true for so many
Yes,
other
yes.
diseases. And
no
it's
disease
not
has more
It's not
medication.
diabetes specific. But
You
here,
know, and you know what is going to be a game changer?
what's that?
What is going to be a game changer? Because we have the issue of adherence. But it's another term that we don't use very often, which is persistence. Adherence is when people don't take the medicines as supposed to. Adherence is when the people in the Medicare gets in the Medicare hole, and then they don't have enough money to get there. And so it takes, instead of taking twice a day, take it once a day so they can have enough medicine, so there's adherence. Persistence is when people stop the medication altogether. And there is this new device that is now in development, and Bob Henry, we have work on that, is a much-sized implant that you put in the subcutaneous tissue, where it delivers medicine continuously for 6 months, and even up to 1 year. We can deliver a GLP-1 receptor agonist, exenatide. And there's no question of adherence, there's no question of persistence. You just implant it and you know that the medicine is there.